Hello and welcome to this video. My name's Kris, I'm an Australian GP, and today in my Health Conditions 101, we're into the E's and I'll be talking to you today about endometriosis. If you want to know more about endometriosis, what it is, how it occurs, how we diagnose it, and why it's so hard to diagnose, please keep on watching. But don't forget to like, subscribe, and comment. What do you want to see from me next? So endometriosis, colloquially known as endo, is a significantly debilitating illness that affects so many people worldwide. To talk about what endo is, we need to talk about what normal physiology of a uterus is. So we've got the uterus. It's got a muscular layer, and the innermost layer is known as the endometrium. So endo meaning inner. And this is the lining that has a lot of vascularity with it, so a lot of blood flow. And it grows and then is shed during a normal menstrual cycle, and is the lining that is needed for a fertilized egg, that is egg who's met sperm, to implant and grow into a fetus, to develop a pregnancy. No endometrium, no pregnancy. So you kind of might see the link now, endometriosis, endometrium. So, okay, but what is endometriosis? Remember how I said we've got the uterus and it's got the muscle lining and the inner lining? It's built to hold that inner lining, the endometrium. Endometriosis is a condition where that inner lining, or at least a lining that is very, very similar, actually is anywhere else but inside the uterus. It can be on the bladder, the bowel, the ovaries, the fallopian tube, just floating around in the abdomen. I've seen them on the liver, the stomach, anywhere. The thing is, this lining is not just hanging out in a random space, but it's actually responsive to hormones as well. So when you have that ebb and flow within the uterus because menstrual cycles and blah, 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 that same thing is happening elsewhere. And the bowel, the bladder, the ovaries, the fallopian tubes, the whatever, are not built to deal with this sort of tissue. So there's a huge inflammatory response, and it's so irritating to these organs. So yeah, it's awful. And I can't, stress that enough. People who live with endometriosis describe it as the most debilitating thing. One of the difficulties is that we don't actually know what causes endometriosis. There are several theories about genetics and about hormone responses, and that during the development of a fetus who then develops a uterus and ovaries, etc., that the lining tracks. There's some evidence to say that some procedures like a cesarean section can lead to endometriosis if parts of that endometrial tissue is taken and left in the cavity. But the truth is we don't know, and that's really frustrating. But a lot of research is going into figuring out how it occurs, because the more we know about how it occurs, the more likely we are to find a treatment that really, really helps. Do not fear though, we can manage endometriosis. So I suppose I've mentioned there's a lot of pain and it's debilitating, but what else do people with endometriosis say they go through? What symptoms are there? It varies from person to person, and it depends on the severity of endometriosis. But some of the most common symptoms include really painful periods, really heavy periods, symptoms, especially again around your period, of really bizarre urinary symptoms, so needing to urinate a lot, blood in the urine, really irritated bowels, so having more commonly diarrhea or very painful bowel motions. There may be pain during sex, bleeding after sex if there's endometrial tissue on the cervix, for example. People also describe a debilitating fatigue. It's really hard to say, but pelvic pain is probably the most common thing. Something else linked to endometriosis, other than obviously the things I said, is infertility. That is difficulty falling pregnant. And it's not necessarily something someone will experience and say, oh, I feel infertility. But it can be a consequence of endometriosis. And sometimes the infertility part is what leads us to a diagnosis of endo. So why does it take so darn long to diagnose someone with endometriosis? The thing is, it's not something we can see very easily or take a history and get a clinical diagnosis, because there are lots of different things that can cause all those symptoms I mentioned before. Ultrasound is not the best modality to diagnose endometriosis, as you can't always see it, nor is CT or MRI. In fact, one of the only, if not the only way to diagnose endometriosis is actually to open you up and have a look at the insides. So this is done via laparoscopy, which is keyhole surgery. And it's during this that we can actually see endometriomas, or little deposits of endometrial tissue, which is the endometriosis itself, and diagnose it from there. Quite commonly during these keyhole procedures, we will biopsy that tissue to confirm it is what we think it is. But yeah, it's pretty much the only way to find out. Of course, during the workup for endometriosis, someone might undergo a lot of testing, including hormone panels, full blood counts, iron studies, ultrasounds like I mentioned before, liver and kidney function tests, all sorts of things to rule out other causes for their condition and their symptoms. Endometriosis has a couple of grades, 4 in fact. Grade 1 is where there is scattered amounts of endometrial tissue throughout the pelvic organs. Grades 2 and 3, it's kind of the mild to moderate version of endometriosis. And this is where that endometrial tissue is not just scattered, but is beginning to infiltrate the organs in which it's attached to. And stage 4 is the most severe, and that's where it's very widespread and or it's causing a lot of distortion within the cavity, and or there's quite a lot of adhesions or scarring, or everything becomes really sticky together, and that's very difficult to treat. So treatment. How do we treat endometriosis? Well, it varies. Not everyone will respond to the same treatments. Depending on the severity, we may offer some things and not others, but generally we've got hormonal contraceptives, which reduce the body's ability to respond to hormones, therefore you don't get that fluctuation during the month. The best contraceptive option for endometriosis is the Mirena or Kyleena IUD, so the hormonal IUD. But contraceptive combined pills can be very helpful, depots, implanon, all sorts of things. The next thing is non-hormonal medications, which can be used in tangent with or instead of the hormonal ones. And these are typically non-steroidal anti-inflammatories that we use for things like heavy menstrual periods or painful periods. So tranexamic acid, mefenamic acid, naproxen, high-dose ibuprofen, all of these can be very helpful for endo. Ultimately though, some people require surgery to deal with their endometriosis, to either take away some of the endometriomas or to reduce the stickiness and the scarring on the organs, but this obviously comes with its own pros and cons and would be done in tangent with discussion with an obstetrician gynecologist. The last thing is endometriosis is not just a diagnosis that is treated by a doctor. It is something that we get a multidisciplinary team involved in with to help you. So if you have problems with your bowels, a dietitian can be really helpful to help with your gut health. A physiotherapist can be really good, especially if you get pelvic pain or difficulties with sex or inserting tampons, that sort of thing. Psychologists can be really helpful too, to work through the complex emotions with such a disabling illness. And obviously, your GP. I mentioned doctors before, but I'd like to give us a little shout out because we can be very helpful. That sounds awful, I know, but seriously, we're here for you. So I hope you've learned something about endometriosis. If you have any questions, let me know. If you have any video requests, let me know. But until next time, guys, do stay safe, stay healthy, and I'll see you in a video very soon.